changed and I can't tell if I'm live. Well,
It says it's now streaming live.
perfect. Okay. Hey, everyone, and welcome to Chef AJ Live. I'm your host, Chef AJ, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, I thought about canceling today's show in the wake of some very unfortunate news for the plant-based community. Our beloved friend and mentor, Dr. John McDougall, has passed away, and I thought about canceling the show. However, I know that the message of plant-based nutrition is very important to Dr. McDougall, and he would probably want the show to go on. We will give you, I don't have any updates other than what I read on the Facebook and social media pages of Dr. McDougall, and they sent out an email. All we know is that he did pass away peacefully in his sleep on Saturday at the age of 77. He was very important to me and my family and our lives, and did so much for so many people. He was truly a legend, and no one will probably be able to fill his shoes. I had the privilege of having him as my guest on Chef AJ Live every single Monday for over 4 years. And there are over 50 videos, many 3 or 4 hours in length, where you can see him discuss many topics on health, nutrition, cancer, heart disease, diabetes, autoimmune disease. And we will forever cherish those memories. And he will be forever in our hearts. Without further ado, we have today's guest. Because it is the last Tuesday of the month, it is time for Move Well to Age Well with our resident plant-based physical therapist, Eileen Kopsaftis. And today, she's talking about something that thankfully I've never had, but I've heard it hurts a lot, and I know some people that had to have surgery because of it. Bunions. Please welcome her to the show.
Thank you, AJ. And my heart does go out to Dr. McDougall's family and all the people that he left behind. As you said, no one will ever be able to replace him, ever. So, okay. On to the topic at hand, bunions. I would love to have heard what Dr. McDougall would have had to say about this. I never heard him talk on this topic. I might search his website and see if he's got anything. But in the meantime, I do have some slides prepared here, so I'm going to go ahead and share my screen. And hopefully everybody can see this. And I tried to prepare this because I always want to give people a strategy, something they can do to address the issue. And I have never spoken publicly on this topic before. I've worked with patients in a clinic setting, but I realized that I was trying to think of something that would really benefit your audience. And I know this is an extremely challenging issue, and it's really prevalent, a lot more than I was aware until I started looking in some of the statistical data. But because of this topic, I decided to do a 3-day challenge, which is absolutely free, to provide more information than what this one show can provide. And the link is at the bottom here. I apologize, it's kind of lengthy, but I sort of created it at the last minute, realizing that this could potentially help a lot more people because some people watch this by recording. And it's a really intense topic. As AJ said, a lot of surgery, it can be extremely painful. It ranges anywhere from minimal to severe, really impacting gait, quality of life, a lot more than people are aware. So I wanted to provide this to everyone. As always, this is for educational purposes only. I'm certainly not diagnosing anyone or providing any treatment here. Please check with your healthcare provider to be sure that you can participate in whatever I'm teaching and not cause any harm to yourself. So I wanted to update the bunion statistics here. I've researched this before, and I was surprised that it's actually found in actually it's about 2.5% of children ages 9 to 10. So it's not just adult onset, it can happen in children. And I know this, I remember having a patient in the clinic, she was 11 might have been a little bit older. She was an athlete from the local school, and she had had bunion surgery at like the age of 9. So it can happen in children. The scientific term is hallux valgus because the great toe. And then what it's doing is it's moving toward the second toe. Sometimes it'll overlie the second toe. Sometimes the second toe will start to move over the top of the great toe. You can see this is a pretty severe case, and this is mild to moderate. And it ranges in any of these stages. Now, it does occur in almost half of adults. I was shocked to see that statistic. And it does have a greater prevalence in women. And currently, 65 million Americans are affected by a bunion deformity. And I'm thinking other countries as well. And there's some talk that hypermobility of the first ray, hyper, which means it's moving a little too much. And the first ray is the bone in the foot that goes to the great toe, goes from the midfoot to, to the ankle bones to the bottom of the toe bones. And then excessive foot pronation. And we'll talk about that a little bit. But it's seen that these are associated with a bunion deformity. Now, not everybody who has this has bunions, and not everybody who has bunions has this. So it's not a clear relationship, but it is seen to be associated. And the interesting thing is some of the research says that an increase in the severity of this issue is seen to progressively reduce both general and foot-specific health-related quality of life, because not only can it be very painful chronically, but it also can impact gait. People don't want to go to the beach if their feet look like this. They don't want people to see their feet. It can be very embarrassing to some. So it's really a quality of life issue, not just the pain. So I'm going to look briefly at some of these things because this could be a 3-day seminar. So we're going to look at what some of the reported causes are, and also some of the causes that may be unknown to most, which is what I like to teach, things that you can't just find on the internet. And then the treatments, strategies, and I'm going to show you some trainings, a couple of movements that you can do and sort of assess yourself. But here, this X-ray here, this is the great toe, which has 2 bones. Your smaller toes actually have 3 bones, but this is the first ray. And you can see here, that's why they're saying it's hypermobile, because it's moving too much. But what causes that hypermobility? So let's look at reported causes. There are a lot of them, and none of these are carved in stone. None of these are absolutely proven. Some of these are just thought processes. They might contribute to the issue, but obviously everyone who wears certain shoes don't get bunions. Some people get bunions who've never worn shoes. Believe it or not, it happens in countries where people are mostly barefoot. And then genetics. Well, if it's only happening in one foot, how can that be genetics? And it can skip generations, or you could have nobody in the family having them, or everybody in the family having them. There's no straightforward anything on that, and no gene has been determined. Decreased ankle function and decreased hip function are some of the mechanical reasons or that can contribute to this. So we're going to talk a little bit about each one of these before I show you some movements. Footwear. Sorry, did I skip one? No. So footwear, toes need room. You can see here on little ones, their toes are actually the widest part of their foot. So when we look at shoes, when you look at baby shoes, you can see here, it's nice and wide. So nobody is squishing the toes on this little one. And even here, the sneakers for a younger child is a nice big wide toe box. But look at how it starts to narrow when you get into the adults' shoes. Obviously, women's dress shoes very much narrow and push those toes in and squeeze them. And even men's dress shoes do the same thing. You know that the foot, if it was not in this shoe, those toes would be a lot wider than this toe box. So footwear changes from baby to adult. Why? Why does that why have we done that? Is it just looks? I'm really curious. I would love to study the history of shoemaking and who determined why shoes would start to not fit the human foot. And I did want to say that there are many people who wear regular shoes who do not get bunions. And again, as I said, there are people who get bunions who've never worn shoes. So it's not a clear relationship. Genetics. Do we actually inherit bunions? Are we modeling the gait of the adults in our lives? I don't know if you've ever seen a child who walks behind an adult, whether it's a parent or a grandparent, and they like to mimic what they see. So if you see an adult who's kind of walking with their feet splayed out, their toes splayed out, almost like a duck walk, a child behind them would start to do the same thing. Children mimic what they see in adults. So could it be that they're modeling the gait of an adult? And that's how, because they're altering the mechanics of what's happening with their feet when they walk, could that be potentially a cause of the bunion starting? And then, as I said, if it's only happening in one foot and not both feet, how can that be genetics? That doesn't make sense because, you know, the genes are throughout the body. So let's look at some studies. Some studies do suggest that congenital and juvenile bunions, so, you know, it's happening very, very young ages, may be related to joint deformities that could have a genetic cause. But again, it hasn't really been shown or proven yet. There's one study that shows 90% of people with bunions had a family history of the condition passed down through generations, but only one. Other studies, no specific gene that causes bunions, and little is known about the genetic contribution to bunions that develop later in life. So when you're looking at extensive research, and I don't know that I would claim I've done extensive research, but I have searched for quite some time now to prepare for this. And I will be doing a lot more research before we do the live event the end of July. So the firm answer to the question, are bunions genetic, is no. They're not genetic. Even though you know, there's been a lot of debates among researchers about this and medical professionals, but it's pretty clear that there are other factors, potentially lifestyle, footwear, foot structure, movement patterns play a much larger role. And I'm going to talk about the biomechanics shortly, which I believe, based on my own experience and knowledge from what I've done for 30 years, is really the basis for this. You know, it's been observed when you're wearing tight, narrow, high-heeled shoes, it can lead to bunions, but not everyone gets them. Some women will wear those tight, narrow shoes and they'll only get a bunion on one foot, not the other foot, and they're wearing the same shoes on both feet. So we can't really blame that. Yes, more women have foot surgeries than men. Women do tend to wear narrower shoes, high-heeled shoes that puts a lot of pressure on the toe, more so than men. But I've had men in the clinic in their 70s who never wore high heels, as far as I know, and they had some pretty severe bunions. So, but then again, men's dress shoes, as I just showed you, very narrow toe box. So there's a lot that goes on, but foot structures. Someone who has excessively pronated feet or flat feet, low arches, that can contribute. And I'll show you that, including down when I get down in the gym. And of course, those things aren't really linked to genetics, but they're kind of like lifestyle choices and physiology. So, and there are certain movement patterns that will provide excessive pressure and friction on the big toe joint. Certain activities that will cause this repetitive foot stress. Again, that's going to depend on the mechanics of the person's foot, the position, how they are performing the movements. So I think it's really crucial to note that it's not really the activity itself that's causing it, but the way the activities are carried out. So we really need to be looking at a very holistic approach for bunion prevention and treatment. And we need to be looking at all of the factors in someone's life. Oops, sorry. So there's some other studies here. There's lifestyle factors, like I said, foot structure, footwear choices, movement patterns that are definitely seem to be much more important than genetics in causing them. And here, just an example, ill-fitting shoes can put abnormal stress on the big toe joint, which can lead to instability and bunion formation. But again, not always. Yes, women are 10 times more likely to develop bunions than men. Maybe it's the shoe choices, maybe it's not. Women do have a very different anatomical makeup. They have a different hip angle. They have a different knee angle. So that could be putting a very different emphasis in physics to their feet and how the toes are performing depending on their own biomechanics. So that may be part of it. Women have a different shaped pelvis. They have a different physiology. So that could be it. It may have little to do with the shoes. So just to wrap up the genetic thing, and I know when I was doing research and looking at some different YouTube videos from some experts and seeing what they had to say about it, because I was curious what research they may have come across. It was interesting because there were many comments in the chat where people were saying it's genetic, and they were just adamant that it was genetic. But it is now widely accepted among those who follow the research, bunions are not genetic. They're significantly influenced by footwear, foot structure, and I believe the biggie is the movement patterns. So let's look at some of these. Ankle function. How well does the ankle dorsiflex? And is the foot in excessive pronation? So let me show you some pictures here. Now, oh, and I want you to remember this picture here when I go downstairs. I'm going to demonstrate if you are taking a step and the foot is turned out and you go to push off the toes, guess what? That big toe is going to go sideways because of that foot being turned out. It has to go sideways. It's a physics thing. So, repetitively, that would be a gait that could really lead to bunions. However, not everyone who has that gait gets bunions. So it's a really sort of it's not a clear picture. But let's look at dorsiflexion. Dorsiflexion is when your toes lift up and your heel stays down. That's dorsiflexion. And there are many people who are lacking optimal dorsiflexion. Many, many people. I cannot tell you how many people I've had in the clinic setting or doing consults online where they had a history of some kind of an ankle issue many, many years ago, maybe as a child or as an athlete in college, and never thought twice about it. But 10 years later, 20 years later, they're dealing with hip issues, knee issues, low back issues, all kinds of issues. And when we assess, we find that their ankle function is greatly limited. And when we improve that, they notice their symptoms pretty much everywhere else in their body improve, decrease, resolve. So it really, what's happening from the ground up is key. But if there's a dorsiflexion issue, what happens is it puts a great deal of increased pressure on the toe joint with every step you take, because there's not enough dorsiflexion happening at the ankle. So that could be part of it. We've also got the pronated foot. Now, these are excessively pronated feet. You can see there's no arch here, completely flattened foot, completely flattened foot. But I also want you to notice there's no bunion. This person has an excessively pronated foot, both feet, and no bunion. So it's not a clear causation, but it's seen to be something that could be contributing. Hip function. This is internal rotation. So basically this foot is stays still, and this foot came around in front of this foot to make a capital T. Those of you who follow my teaching, you know I teach internal rotation a lot. It's really required for all kinds of things. When you do internal rotation, it actually pulls the foot into supination, which is the opposite of the flat foot, the pronated foot. So it is something that if the hip is lacking internal rotation, it can inhibit the foot from coming out of pronation. So they do go hand in hand. It is a great big chain reaction, which I'm going to kind of talk you through using my foot bone model that I have downstairs in the gym when I get down there. So recommended treatments. Well, there's a lot of things. If you go and do an internet search, your eyes will glaze over with how many options you'll see. So I am certainly not going to show all of them or even a small percentage of them. I'm just going to touch on them briefly because, again, we could be here for 4 days. But when it comes to surgeries, they're constantly coming up with new surgeries. I was reading some surgical studies to see, and from what I can see, there really isn't any clear conclusion as to which surgery provides the best benefit as far as alignment and pain reduction, pain resolution. Certainly, many people have had bunionectomies and it has resolved their pain. It has improved the look of their foot. Unfortunately, a lot of the times they will do a procedure where they are fusing the joint of the toe. And so now the person can't really, the toe doesn't bend. So now their toe off is altered for the rest of their life. Their gait has to be altered because of that. And there are people who have bunionectomies who, when the biomechanics have not been addressed, they end up having another bunionectomy or just a recurrence of the bunions. So we really need to be going after the cause, not just a surgical correction. And of course, if someone is in extreme pain and can't walk, quality of life, sometimes the surgery feels like it's the only answer. So, you can get injections, take NSAIDs, these kind of things. Study-wise, these aren't really all that effective at doing anything. From what I could see, I'll just sort of give you the cliff notes of all the studies that I've read so far, and I'll be a lot clearer on this in the Bunion Challenge. But so far, what has been seen is using toe spacers and proper footwear so that the toes aren't being squashed can make the biggest difference. Just changing footwear doesn't change the alignment of the big toe if there's a bunion. At least the data doesn't conclude that. The data does conclude that toe spacers with proper footwear can make a difference. So I just wanted you to know that right up front. So some strategies. Obviously, we want the toes to fit in the shoe, not be squished. So I found this picture and it was perfect. This is your standard athletic shoe, and you can see here obviously that it doesn't fit the foot. Those toes are going to have, this toe is going to have to be pushed in. Even a wide shoe. So a lot of the times people they'll buy a shoe and they'll buy a wide shoe and they think that's better because it gives more room for the foot. Well, it's actually wider for the foot, but it's not wider for the toe box. So it's still not fitting the toes correctly. What you really want is a foot-shaped shoe. And you can see here, it doesn't curve in where the toe is. It goes straight down and the entire foot can fit in here. And a way to tell if you're going to buy shoes is just take the shoe and turn it over and put your foot on top of it. Obviously, you'd need the opposite shoe so that it would fit right properly. And see, if your toes are splaying over the sides of the shoe, it's going to be shoving the toes in, which is not a healthy gait. You really want your toes to be able to spread when you walk. It is much, much healthier. All of the things that you can get for bunions to address things. You've got the cushion here. It's a toe spacer here, reportedly pushing the toe out. If it's a severe bunion, all you might be accomplishing is pushing the second toe over. So you have to be careful with that. This one is providing some pressure here so that it's not pushing it over into the second toe. It is aligning it better. This can sometimes, you would wear these at night. It can sometimes really alleviate the pain. You've got ones that are, this is real splinting. This is a lot more. You can't really put these in shoes, but it can make a nice difference for addressing pain. And then you've got simple things like this that just kind of helps your feet to stay separated. These toe spacers, these are kind of what I was talking about. If you're wearing the toe spacers with the shoes that align better, that is seen in the data to have a much better effect. And then, of course, there's orthotics. If someone has real excessive pronation, orthotics may be recommended. I'm really on the fence about orthotics because your foot is a very dynamic part of your body. You've got 4 layers of muscles in your feet. And when you're using, and please don't hear what I'm not saying. I'm not telling anyone to stop using their orthotics, not giving anyone orthotic advice. I'm simply talking about the physiology of the foot. When you put something rigid to support the arch, you're not allowing the muscles to perform the way they're designed to perform when you're walking. And so, and you're not, and I'm going to explain the gait when I get downstairs using my bony foot model. that ideally the foot needs to pronate initially as you're doing a heel strike. And then all kinds of stuff happens all the way up to the neck of the body, all the way back down to the foot before you toe off. And that's when the arch occurs and you want the supination. So ideally, the foot needs to go back and forth between pronation and supination. If a person's really excessively pronated with no arch, they're probably not supinating. But it seems to me that ideally working those muscles and attempting to address that issue would be a good strategy. Again, I'm not telling anyone not to wear their orthotics. If you've been told to wear them, follow the advice. Get some different opinions from different experts. So, all right, so this is just a reminder that at the end of next month, I'm going to be doing this challenge. It's completely free. I really want to help as many as I can with this topic because it is so intensive and requires more time. And right now, I'm going to head downstairs so I can show you some training with some movements that will potentially help you.
Thank you. Hey, I lost my voice because I've had to have so many hundreds of phone calls today. People calling me about Dr. McDougall's passing. I've literally been talking for about 6 hours straight.
Oh, yes. Okay. Well, I will be about 30 seconds.
Thank you. I apologize.
Just how about just doing a moment of prayer for Dr.
Yes, actually, that's a good idea. While Eileen is going down to her office, since I'm having trouble talking because of talking so much, why don't we just have a moment of silence for Dr. John McDougall? Back to I can't talk. Back to Eileen. Here. Eileen, you're muted.
Oh, I thought I hit it off. I'm sorry. Can you hear me now?
I can hear you now.
Okay. All right. I apologize. I could have swore I hit it. So I want to show everybody the foot model here. And you can see here that the heel bone is how you land on your foot. And so the outer edge of the heel bone is the optimal place to land, just outside midline. So we're not talking way out here. We're talking just a little here. And because of that shape of that bone and gravity and ground reaction force and mass and momentum, it's all the physics stuff, it allows the heel to sort of drop down like this, which causes what's called eversion, and the heel goes that way. So when that happens, it also has to happen in dorsiflexion, which is because you're landing on your heel, you have pulled your foot up and you're landing. There's a bone here called the talus. It's the only bone in the body that has no tendons attached to it because it doesn't rely on muscles to move it. Bone is pretty much the slave of muscle. Your body isn't going to go anywhere. Your skeleton goes nowhere without muscles pulling it and moving it. But that particular bone completely relies on the motion of the bones below it, or the heel bone, and the bone above it, your shin bone. So what happens is when you land on that heel and you drop down and that everts, it causes that talus bone to rotate down and in. And I don't know if you can see this, but when I do that, you can kind of see the foot sort of spreading a little bit wide. Obviously, this isn't a living model, but it's spreading out, which means it's pronating and it's opening. The arch is dropping so that it is a nice, flexible, shock absorbing foot, so that whatever you might be stepping on, whether it's an uneven surface or there might be a pebble or something like that, the foot can absorb the shock, so you're not getting jarred in your head every time you take a step, and it can handle any uneven things going on. Now, all kinds of stuff happens above there because that drops down and in and that pronates. All kinds of things happen. This internally rotates, which is why that internal rotation of the hip is so important, because the shin bone turns in, your thigh bone turns in, and all kinds of other stuff happens, which I could go into ad nauseum, but I don't think anybody wants to hear it all. And then because of that, it gets all the way up to here, and then there's a reaction that occurs. So it's kind of like things are winding up, and then they're unwinding to go back down. So as it goes back down from the upper body, now the thigh bone rotates out, external rotation. The shin bone externally rotates. And when that happens, that talus bone that's counting on the movement above and below without muscles doing anything, it reacts and it rotates up and out because of this. Now you can see this as I do this. What that's doing is that's pulling the arch up. It's literally creating supination and an arch in the foot. So this is why there's so many mechanics of the body that can impact what's happening with the foot, which ultimately impacts what's happening with the great toe. So, and as I had said earlier, they're talking about potential hypermobility of the first ray, this first bone here that goes from the ankle bones to the toe, or I should say the rear foot. It can be hypermobile, but not everyone who has bunions has a hypermobile first ray, and not everyone who has a hypermobile first ray ends up with bunions. But we do see that as this turns in, this ends up coming out. And that's why we end up with the bump here. So there are a lot of people out there that are providing advice and recommendations and recommending procedures and treatments, all for this topic. Unfortunately, I would liken it to sort of a quagmire. You don't really know. You're doing your internet search. You're attempting to figure out what is going on, what you can do. You're in pain. You can't walk properly. Shoe wear is a nightmare, and you don't know what to do. So that's why I'm creating the challenge. I want to really provide information that I have vetted, information that I have actually applied in a patient population, things that I can say that are potentially beneficial with no potential harm. That's always my goal. So what I want to do is I want to show you some movements, and I'm just going to change my view here so I can see what you're seeing and make sure that you can see this. So the goal here, and I have these darker shoes on, and so I put the blue down so you can see where my feet are. But these are shoes that I like. I'm not recommending any specific brand, but I will tell you that these shoes are Topos, T-O-P-O-S. They do have a beautiful toe box that goes straight. It doesn't push my big toe in. My feet can spread. I could actually wear toe spacers and wear this shoe, and there would be no pressure on either the big toe or the baby toe. And I know some people have what's called a bunionette or a tailor's bunion on the baby toe, which is a similar issue. I'm not going into that in detail today, but I will cover that in the challenge. So what I want to show is how to improve dorsiflexion. But first, I wanted to remind you of that picture I showed you when I was still upstairs, that if you go to take a step and your foot is rotated out, and you can go ahead and stand up and try this, even if you don't have a bunion, if your foot's turned out and you land on your heel and you go to step forward with the other foot and you go to push off, you can see that toe is going to go that way. It's going to push the toe in. It can't possibly stay straight. Obviously, if my foot is straight, I will come off the toe and the big toe is straight. But if my foot is turned out, it forces the big toe in. So that is huge. And a lot of the times people will do that if they have lack of dorsiflexion, because you need to be able to bend the ankle and bring the toes up. If you don't have enough dorsiflexion, what happens is when you go to take the step, because I can't dorsiflex, I'm pushing off. There's a lot more pressure going on that foot, abnormal pressure. So we really want to increase the dorsiflexion. What we want to do is address any of the potential mechanical reasons that the bunions are created, existing, or to prevent from occurring. So I'm going to show you how to mobilize the ankle and improve dorsiflexion. And then I wanted you to assess this. I want you to look at what we call a hip matrix. And for that is you can rest your hands on your hips just to sort of give them a manual cue here. And when you do movements, I want you to notice what's happening down at the ankle. So if your hips go forward, you notice that you are going forward and you're getting a little dorsiflexion in the ankle. And then when you go backwards, you're getting a little plantar flexion where the toes are pointing down. So you're getting that ankle motion from that. If you do a little bit of a sideways motion, this is encouraging your heel bone to go in and out as your ankle is turning slightly sideways at the ankle joint. So again, this is going to shift what's happening in the foot. And then the last thing I wanted you to notice with the hip matrix, a matrix is anything where you move in 3 planes of motion. For those of you who aren't familiar what I teach, as a human being, we move in 3 planes of motion. We move forward and back, we move sideways, and we turn. And every movement we make, no matter what it is, incorporates all 3 planes, some more than others, depending on the movement. And then if you're familiar with the robot dance, they're moving 1 plane of motion at a time. So that's why they look so robotic. So when we do the third part of the hip matrix, which is rotation, that's where we're getting the supination and pronation. And I wanted you to sort of assess this on yourself and just notice what you feel. So if you're standing there and you are rotating, if you're rotating over your right foot, you will notice your left foot is pronating. It's collapsing down and in on the inside. You will notice that your right foot is supinating. You can feel the arch pull up. You can feel the weight go to the outside of the foot. Now, even if you have excessive pronation, rotating like that on your feet, you will feel something change. You will feel the pressure go to the outer edge of the foot. Even though if the muscles of the foot aren't able to keep you there, just rotating the upper body on the foot, you will feel that change in the weight bearing. And then, of course, if you rotate over your left foot, you'll feel the opposite. You'll feel the right foot kind of collapse down in on the inside, which is pronating, and the left foot will be supinating. So the pressure would be on the outer of the left foot. So just notice that, just that alone. Now, a lot of the times people will think, oh my gosh, if I'm excessively pronated, I don't want to do anything that moves me into pronation. But ideally, what we want to do is we want to train those muscles, and you've got a lot of them. You've got like a dozen muscles that go from the calf down into the foot. And those muscles, depending on which one, are responsible for controlling how much you pronate and then pulling you out of it. So muscles will, and I think I have my monkey down here, do I? Sometimes I bring him upstairs and he's not down here. But muscles like to work by getting longer under tension. So those muscles that are controlling how much your foot pronates are getting longer under tension, and then their goal is to stop it before it's excessive and then pull it back out once that talus bone starts rotating up and out and it shifts the direction of everything. Now the muscles start to help with that, because it's kind of like, think of a slingshot. It'll, you know, the rubber band only goes so far, and then when you let go, it comes back. So that's what we want to be happening in the feet. So so ideally, doing this could potentially wake those muscles up. Now, again, I'm not treating anyone here. I'm just giving you some general understanding of the mechanics of the feet and how much it's related to upper body movement as well. So just sense that pronation, supination. And there's also something called a duck stand. Now, I have a Bosu ball here. I don't know if many of you are familiar with this, but a Bosu ball can be very, very helpful standing on it and doing what's called a duck stand. So what a duck stand is you're not turning your feet out. You're keeping them flat. Try this on the floor first. And then what you're going to do is you're going to feel like your knees are turning out, and you'll feel your butt cheeks kind of squeezing together, and you're trying to turn your knees out. Think of them like they're little flashlights, and you want to get them to turn that way. And you're going to feel the arch of your feet pull up. So just doing that motion, I can feel the weight on the outer edges of my feet, and my arches are increasing. There's a higher arch. It's pulling them up. It's called a duck stand, and it can be very beneficial at training your body and your feet. And you can also do this, you can progress by doing it on a Bosu ball, which can really challenge the muscles, the stabilizers. There's all kinds of great exercises that you can do on that. So I just wanted you to see, but it's not required. It's just some of you might actually have one, or you might have access to one in a gym setting. So I wanted you to be aware of that, and you could maybe try it out. But be careful, because it really is testing the stabilizers. Okay, so what I would like to do is I would like to teach you some work to mobilize that ankle, to improve that dorsiflexion, and then show you something you can do that could potentially improve hip internal rotation if that's lacking, because that is required for everything to be functioning correctly. So of course, so is external. A lot of movements are required for us to be working optimally as a human being when we move, but I want to show you a couple of the things that are really important here. So as far as ankle mobility, a lot of you have seen me teach what I call calf loading in all three planes, and I call it loading instead of a stretch, because the goal is it's a dynamic load and unload, which is what we do when we walk. Every time you take a step, you're loading and unloading with every step you take. And so, you know, having a long static stretch isn't necessarily authentic. So we want to try to mimic what it is that we want to improve in our life. And if walking is one of them, then it's a dynamic load and unload, and that's how we want to train the body. So there's a couple of things. I want to show you just the basic calf loading first, which does mobilize the ankle. But then I think I'm going to show you one more thing that could potentially help as far as getting the pronation supination. And then I'll show you the internal rotation move. So the first one is you could go ahead and be against a wall here. The higher up your hands, the more you'll feel it. Get your trunk up higher and extended, and you'll open up the hips a little bit more in the front, in addition to mobilizing the ankle. Or you could hold on to something that's a little bit lower. You could hold the top of a chair, as long as it's nice and stable and you're safe. So I'm going to show you this way so you can see what I'm doing with my feet. But if I put one foot back and the other foot forward, right away now I'm in dorsiflexion, because that toe is a little closer to my shin. If I go back here, now my toes are moving away from my shin. If I do this, those toes are going closer to the shin on this foot, because I can lift my toes up to have it happen, or I can move my shin closer to my toes. Now, if I bend my knee, I'm really getting dorsiflexion. And for any of you who have trouble or pain going downstairs, in your knee and you think it's your knee, it's probably your ankle. And if you improve dorsiflexion, you may notice going downstairs is a lot more comfortable. Your knee really is your upper ankle and your lower hip, but I don't want to digress. So what we're going to do is have a foot back, and you want to make sure that you're far enough back where you're challenging it a little bit and you'll get some improvement, but you're not so far back that you're going to fail at the movement. So you want your threshold. Make sure your toes are forward, because the foot is notorious at wanting to turn out. If you lack dorsiflexion, it wants to cheat. And so make sure those toes are nice and straight forward. And what you're going to do is you're going to keep your heel down and your hips are going to come forward. So you're just going to come forward like this. And if you push your heel down as you do that, you'll really feel that ankle dorsiflexion load. You'll feel that right up into the calf. So you really want to load and unload. Now you'll see I'm not doing this. That would just be a push-up, and that really wouldn't do anything for the ankle. So you want the hips to come forward, head and shoulders stay back. And that's going to really help to load that ankle. Okay. Now, remember I said we move in all three planes of motion, and that's just forward and back for dorsiflexion. We can add the side movement as we're in dorsiflexion, as we've got those toes closer to the shin. So I can come forward to get it in that dorsiflexed position, and then my hips can go side to side, and I'll show you from the back so that makes better sense to you. So I'm coming forward to get the ankle dorsiflexed and pushing that heel down, and then my hips go side to side, and now we're getting that side movement of that heel bone going out and in. And we want that to happen because that's what's helping that bone on top, that talus, dropping down and in or moving up and out, which is what's causing the foot to pronate and supinate. All of that has to happen together. And then the last one is the turning. Remember, there's three motions, three planes. And so for that one, you want to come forward to dorsiflex, and then you're going to rotate. And this is the pronation supination. And I want you to really pay attention. If you're someone who excessively pronates, what would be advisable is to go a little into pronation and then really push into supination. A little into pronation and then push into supination. So you're training the muscles. You don't want to go too far, and you want to pull up out of it. So with the right foot back, you're turning a little left and then a lot right. A little left and a lot right. And it would be the absolute opposite, excuse me, if your left foot is back, you come forward to dorsiflex. Of course, you do what we already did, where you're doing the forward, the load and unload. You're doing the forward and doing the side to side. And then you're doing the forward. And if there's excessive pronation, you can turn in a little to the right and then really turn left. So that little bit to the right is teaching those tendons to limit how much you'll go into that, and then really pull it up and out. Now, of course, this isn't, one magic movement isn't going to completely resolve excessive pronation, but it's a way to train the body to positively impact, what's happening with that foot. Okay. Okay. Now, the last thing that I want to show you, excuse me, is the hip internal rotation. So the internal rotation of the hip can be done in a myriad of ways. There's limitless choices. I wanted to show you one that would be kind of easy to learn and hopefully potentially keep you from creating any kind of discomfort, because sometimes if you've got limited rotation internally in the hips and you try to get it, it can sometimes trigger pain for people, low back pain, hip pain, knee pain, because a lot of the times people are they're gung-ho, they're going for it, they don't realize they're limited, and then they wish they hadn't done it. So what I want to show you is, let's do sort of a tease your way into it to see what you have. So ideally what that would mean is you can hold on to something, And I'm standing on my right foot, and I'm going to take my left foot and I'm going to just turn it in a little in front of that right foot, and then I'm going to bring it back to start. So I'm just going to turn it in and see how it feels, just kind of testing the waters. And each time I do it, I can go a little bit further, just a little bit further. And I'm seeing what's happening here with this hip. Is it okay with that? I can feel that, yeah, I can feel it tensing when I go that far. And so you might want to stay where you're just feeling it get tense, but don't try to get the entire movement right away if you notice there's tension. If you have no issues, no pain, your knees are good, your hips are good, then, and you feel comfortable and you believe it's safe and okay, you can go a little more. And you can even get to the point where you're staying there, kind of hang out there, and then take the arms and keep turning. So that's going to give a little bit more. So, and I'll show you this from the back view so that it might make better sense to you. So I'm going to take my left foot and put it in front of my right, kind of like I'm making a capital letter T. And I'm going to take my arms and I'm going to rotate more to the right. So this is a real internal rotation on that right hip, but we're kind of doing it piecemeal, inchworm. I made my own word. Inchworm and piecemeal, I made my own word. And then of course you want to make sure you're doing both sides. So you would take that right foot and just start going in front of the left. And I'll turn a little so you can see what I'm doing. Just turning a little bit in front of that foot. And after a few times you've warmed it up and you feel like it's pretty comfortable, then you can go all the way. Arms are out, and you're going to rotate more to the left. Now, you'll notice when you do this, you're also supinating the foot. So we're pulling it out of that excessive pronation, and we're doing a nice internal rotation of the hip and supination of that ankle. So that's the opposite of a flat foot. So you're promoting those good things. There's lots of other things you can do. I plan on teaching quite a few movements, 2 or 3 workouts in the Bunion Challenge. And hopefully that you've all benefited from this. And I don't know if there are any questions. I know Chef AJ, her voice is pretty much gone.
There are some questions. I'll do my best to get through them. Norma is asking, do you provide exercises to correct forward head posture? How often do they need to be done? And are they usually effective in correcting this condition?
That's a really good question. Forward head posture is due to different mechanics in the body. So oftentimes, because we do a lot of sitting, the muscles, the hip flexors tend to lock a little bit short, which can sort of pull you forward a little. And you only need to go forward a little. I know we sort of forget about gravity unless we drop something, and then gravity takes over. But gravity does impact our bodies, and we're kind of like an accordion. And what can happen is if you end up forward a little bit, gravity just keeps pulling you forward and down. So working the hip flexors to really open them up so that you can be up taller without your body fearing that you're going to fall back and smack your head open. A lot of the times there's some weakness in the front of the body, the anterior chain, and a lot of that has to do with sitting and, of course, core weakness and things. And I'm not just talking abdominals here. I'm talking the whole trunk and the hips. So what happens is the stronger that part of the body is, the more able a person is to stand up nice and tall with no fear of falling backward, feeling completely safe. That makes a huge difference. So there's a lot that can be done to get a person's posture better. I also teach a monthly melt class, which can really alter the posture in like 15 minutes. So there are some very effective strategies that can be done. Yes, very effective. I've seen people, I had I had a patient once she was in her 90s and she was determined to improve her posture. I was seeing her for a different thing. But when we first put her against the wall and the wall was behind her here, her head was so far forward, we measured, she was 4.5 inches from the wall. Now, she could have done this to touch the wall, barely, but the goal is to get the head back and have it be against the wall. And so she was determined. Well, by the time I was done working with her, and I don't think it took that long, just a couple of months, we got her to where she was only like 1.5 inches from the wall. She gained 3 inches of getting that head back. And I know that she probably got the rest of it after I was done with her, because I wasn't seeing her for that. That was like an added thing we did on the side. So she was doing well. I had to discharge her. I couldn't, justify continuing the medical intervention, but she did beautiful, and she was in her 90s. So a lot can be done. Yes.
Thank you. The next question is anonymous. Dr. Furman was just on the show talking about the power plate, and the person's asking, do you think that power plate vibration machines are healthy and worth the hype?
I've looked into the data. As far as bone density, that was where I really did the study, because I co-created a course with Sid Nodder, which was in one of the bundles for you, Chef AJ. And I did a deep dive into the research, and the research is inconclusive as far as bone density. Some of the research says yes, some of it says it's not really proven. So I personally probably wouldn't. I would concentrate more on doing the weight bearing. Like I said, gravity, ground reaction force, mass and momentum. There's a lot that can be done. Even something simple like and make sure this is safe. If somebody has a vertebral fracture, you wouldn't necessarily want to do this, but just standing and dropping on the heels and causing that jarring through the body can create enough of a stimulation to the bone to have it start to do some more bone remodeling. There's some things you can do with like a 1-inch stepping down kind of. So, and again, it depends on your situation. If you've got active fractures, if you have severe osteoporosis, depending on your Z-score. I don't really like T-scores. I think Z-scores are a little better. But there's a lot that can be done. And from what I've seen, I'm not saying I've seen all the data out there. From what I've seen, I don't know that it's, as far as bone health, if it's as effective as some might say.
Thank you. Next question is from Robin. I have bunions that are inherited. I'm 61 and normal weight. I lead a very active lifestyle, and I eat exclusively whole foods with no animal products for 11 years. Is it a good idea to consider Lapiplasty 3D surgery? Most of the time I'm fine, but my balance isn't as good as it could be, and some days my feet just hurt. I don't like to sit much, and I want to continue to lead an active lifestyle into my later years. Yeah.
So Lapiplasty is one of the types of surgeries that they do. There's another one. I don't know if anyone, I only came across this at a surgeon who's in California, who's doing something called a bunionplasty. And it's supposedly the most minimally invasive, where people are weight bearing as soon as they're out of surgery. So they're not having to be non-weight bearing for 6 weeks. It's supposed to be an extremely quick recovery, minimal scar. I didn't see any data to support how effective it was at results, but lots of before and after pictures. If you go to any surgeon's website who does bunions, you're going to see lots of before and after pictures. Are they showing anybody who maybe didn't have a good outcome? Probably not. So, they're going to show their best advertisements. And I'm not saying that they're not all good. I just, we don't know. So what I do know is they're constantly upping the game when it comes to surgeries. I recently came across one where they're addressing and I don't remember the actual term, but they're addressing that first ray, the hypermobility. And so what they're doing is they're putting it's almost as if you had a fracture. They're putting a metal plate with screws to stabilize this joint between the first ray and the rear foot. And that will straighten the toe. So they're not doing anything here surgically, it's all here. And it pulls that first ray straight, which of course pulls the toe straight. Technically, I mean, I'm thinking biomechanics, that's going to allow the big toe to do the proper job, but we still have the foot being trained so that it's coming out of pronation, it's supinating properly, arch is being pulled up, leg bones are rotating in and out when they're supposed to. Everything else is working right. I think what tends to happen is, we do that. T. Colin Campbell wrote that book, Whole, WHOLE, and he talks about the reductionism when it comes to food and nutrition. And we tend to do the same thing with the body. So I believe that if someone has bunions, there's a lot that needs to be looked at besides just that one joint. And then obviously, if the person's in pain, if it's impacting their gait, they need to make the decision that's best for them. I always tell people the most important question to ask any healthcare provider is, what are my risks and what are my benefits? And while all of the data so far that I've read, and I'm going to be reading a lot more before this challenge, has shown that yes, most of the surgeries will improve the alignment of the big toe so that the foot looks a lot better when you take a picture. But what's happening to the gait? In other words, are they landing properly between the heel strike, everything happening correctly, and then the toe off? Is the toe off happening properly? Because there are people who after the surgery end up with a recurrence of the bunion because no one addressed the gait. So, and as I presented in the slides, the genetics have not been proven. So yes, our mom might have them, our grandmother might have had them, but that's not necessarily the reason we have them. It could be other things that have to be addressed. So hopefully that helps. I can't really advise someone whether or not they should have surgery, of course. And I will be doing a deeper dive into the types of surgeries and looking at the data as far as effectiveness and outcomes.
Thank you. Watching live on Facebook, Mary says, I have right big toe arthritis. Would the things you talked about today help this condition also? It's quite severe.
Well, arthritis, I just did a boot camp on arthritis. We just finished it last week, Monday through Friday. Actually, the recordings are still available until Friday night. So if this person wants to contact me, I'll make sure that, if you need it beyond Friday, let me know and I can help you. But I did all that talk on arthritis. I taught 3 workouts and showed a lot of data. So it's a lot of information. Anything that's going to improve the function of the body, the diet really is kind of the big key factor when it comes to arthritic changes in the joint. The Stanford University School of Medicine did the study, and joint damage is caused by chronic inflammation. And we know food is the biggest offending factor when it comes to that. But if there's ever been injury, trauma, impact to a joint, and it triggers the immune response, triggers inflammation to try to heal the area, it could kind of get stuck on there depending on the damage and the injury. So sometimes that can be a causative factor as well. Anything that improves movement and function and biomechanics of the body is always a good thing. And I always teach it can't be painful. If it's painful, don't do it repetitively because your brain's just going to cheat and you're going to train in dysfunction. And make sure that you're successful doing it. Even if you have to back up and do a much smaller movement, it's a start. Make it successful and then progress from there. Because no matter what's going on, the better that the mechanics of the body are improved, the better the function is going to be overall. So hopefully that helps.
Thank you. Tracy wants to know, can you correct ball of foot pain and what type of sneakers should I wear?
Well, ball of foot pain could be, there's no way of me knowing what's going on, not knowing this person, their history, they're watching their gait, watching how their body moves. So I can't possibly provide any specific advice. I just know that working the big rocks of the body, a lot of the times it's not necessarily where the pain is that's causing the problem. So it could be the ankle's not moving properly and there's excessive pressure going on the ball of the foot. It could be that there's some joint that's just kind of jammed and not really moving properly. So some mobility right directly in the foot could be beneficial. Could be the hips not working right, and there's a problem happening with the gait. So there's a myriad of reasons that it could be causing it. So it's impossible for me to take a guess. I wouldn't even attempt.
Thanks. Valerie says, what is the best for serious bunions? But maybe she joined late because that's kind of what the whole talk was about.
Yes, yes. I recommend that she watches the recording.
Okay.
Yeah.
Cindy wants to know if ankle dorsiflexion issues can cause knee problems. I have plantar fasciitis and wear orthotics.
Ankle dorsiflexion limitations, deficits, impairments can absolutely cause knee problems. As I often tell people, your knee is actually your lower hip because of your femur bone, which starts at your hip and ends at your knee. And your knee is also your upper ankle because of your tibia, which starts down at the ankle and ends at the knee. So what happens below and above the knee radically impacts knee function. I cannot tell you how many people I've been able to help by restoring proper hip function, proper ankle function, and their knees are very happy campers because of that. It's a simple hinge joint and it's stuck between the hip and the ankle with no place to go. So again, we focus on that knee, not realizing that we've got to look above and below to make sure that the knee has proper support and proper teamwork from above. It's very, very important. I mean, the quads that control the kneecap tracking and function, is impacted by the hip. The glutes, gluteus maximus there, and medius and minimus and all the others, and the Gemelli brothers and all. But that comes down, it's diagonal, and it comes into your ITB, your TFL, and impacts the knee. Your hamstrings radically impact the knee because they start at the sits bone and they come down and they go to either side of the knee below it, and they control rotation when you walk. So if you've got hamstring issues, you're probably going to have knee pain or knee problems. But guess what? It's not the knee. So the knee is radically impacted. If dorsiflexion is an issue, it will impact knee for sure.
Thank you. Tanya wants to know, are bunions only on the toes? What is it when you get the bump on the outside of the foot that kind of looks like a bunion?
So I think she's talking about a bunionette. Is she talking about the baby toe?
No, it's like halfway down between the heel and the baby toe on the right or left side of the foot, a hard bump.
Oh, okay. Yeah, that's a completely different thing. Depending on where it is on the foot, it could be the navicular bone. So that's a completely different thing. That wouldn't be a bunion. No.
Okay, thank you. And there's a question from Janet. Is bunion surgery recommended? Does it have success rates? And what type of surgery do you recommend for toes turning out at a 45-degree angle?
So I'm thinking she means turned in and not out. So I'm not recommending any specific surgery because there are way too many of them. You need to speak with a surgeon to know which surgery they would recommend for you based on their experience and what's going on in your world. There's no way for me to recommend any particular surgery for anyone for anything, especially over the internet. But what I will say is you always want to ask lots of questions. You want to ask, what are my risks? What are my benefits? You want to make sure that they have a really good reputation, that, that they're very successful at what they do. And again, there's so many different types of surgery now for bunions. They're coming out with different, more and more, how they're addressing it, which bone whether they're fusing or not fusing, whether they're stabilizing or not stabilizing, which part of the foot they're addressing, whether it's a minimal incision or a big incision. And I was, my eyes were glazing over looking at some of the data because they're even trying to compare the different types of surgeries. And there's not enough data for them to even compare to be able to tell you which surgery has a better outcome, which one has a better pain resolution. They don't even know. So it's a real murky world.
And so my suggestion is always to do what has only potential benefit and no potential harm, which is training the body in a way that it's designed to function and seeing what changes that elicits. If it's something that the person can put off for a little bit and it's not really impacting quality of life or putting them at a high risk of something horrible happening, it doesn't hurt to train a little bit and see what might help. Again, you don't want a recurrence of the bunion. So once a surgery is, you never want to have to repeat it. So there's a lot to it. It's quite muddy. So that's why I'm going to be doing the challenge the end of July.
Thank you. Elizabeth said, what is the name of the shoe that you recommended? And there's also a question if you are familiar with the HIKE shoe advertisement from Mel.
Yeah. So there are an unlimited number of names of shoes that will fit the human foot correctly. I did a research and oh my gosh, there are so many. I couldn't possibly list them all. I haven't tried them all. I haven't researched them all. So there's no way I can really say one over the other. I will say that I bought these and these work for me. I don't know if they'll work for you. These are Topos, Topos. They're a 0 drop, so which means my heel's not higher than my toes, which they've thought that if the heel is a little higher than the toes, it's putting more pressure on the toe joint when you walk because you're kind of leaning forward a little bit. I don't know that bears out in the data, but those are some of the things that are said theoretically. But these are great because it's not squishing my toes. It's going straight down. My toes can spread. I can even wear toe separators in here, toe spacers if I want. And my feet are very, very comfortable. So, just buying wide shoes, I don't know when you came in, if you saw my slides, even just a wide shoe, what it does is the body of the shoe is wider, but it still narrows where the toes are. So it can still push the toes in against each other. It can still force that big toe in. I'm not saying those shoes cause it. They haven't proven that. However, if you've got bunions, it's not going to help you to get the foot straight, and you don't want it to exacerbate or aggravate anything. And so it's always a good idea to, wear things that the human body's actually fits. And so there's a myriad of brands and styles, but the most important thing is that your toes are not being squished in the toe box. That's key.
There's a question, which toe separators work best?
Again, there are so many choices. If I had to recommend a brand, there is a brand that was created by, what is it called? I'm having a brain cramp now. It's toe something, and I don't know why I can't think of it now, but it was created by a doctor. He wears them running. You can put them in your running shoes. I actually bought some because I wanted to try them and see what they were like. They are very adaptable. You can trim them if part of it is bugging one toe, or it's not comfortable here, or it spreads your pinky toe out too far. You can trim that part off. They're very adaptable for you. Correct toes. Yes. They're correct toes. I think those are a good brand, but there's a lot of them out there. But those I like because you can adapt them. They come in different sizes, and you can even you can add to the spacers if you've got a bunionette or the bunion. So I think they're the most practical from what I've seen, and they just don't wear out. They last forever.
And the question is, do we wear on both feet or just the bunion stressed foot?
It's always ideal to treat both feet the same and not one different than the other, even though there's only bunion on one side. If you're going to do the toe spacers, I would recommend both sides just for symmetry. I think it might keep from confusing the brain.
Thank you. And let's see, I saw another question. Are hammer toes caused by the big toe bunion?
Hammer toes are a completely different topic. People can have hammer toes and not have a bunion. So although usually they do kind of go hand in hand. Nobody really knows what causes them. The toe just curls up, and It's either going over or under the bunion, but you can have a hammer toe that's the third toe. It doesn't necessarily have to be the second toe. I haven't done a lot of research on the hammer toes, I'll be honest. It's not a part of my profession where I've spent a lot of time with patients about, but I always want to think what would potentially cause the body to want to make that change. Something's causing it. And that, we can't say that's genetic. We can't say, those kind of things. My thoughts are, again, really good fitting shoe wear, really making sure there's, I teach the melt method every month, and that's really good. There's a beautiful foot treatment in there that can address the fascial issues. Maybe potentially some, and I haven't researched this, but could be maybe some acupuncture, some special massage, special treatment, fascial could potentially be beneficial. But again, I haven't really researched hammer toes, so I can't speak definitively on that.
I don't remember if I asked this, but Rita said, could you talk a bit more about the bunionette?
I didn't talk a lot about that. I will be going into that more in the challenge. I didn't do a lot of research on that yet. I want to update my knowledge before I tell anyone anything.
And people are saying they took your arthritis boot camp and it was great, so they're recommending your next one.
Okay, good. Yeah, we had a lot of fun. Had about 800 people register for that.
Oh my God, that's amazing. Somebody's asking about a duck gait or something. I'm not sure what that is.
I mentioned the exercise. It's called the duck stand. So if you're standing with your toes pointed forward and you pretend your knees are flashlights and you want to try to turn them out, you squeeze your butt muscles and you can feel the knees rotate out. That pulls your arches up. And I was also demonstrating if somebody has what's called a duck gait, where they're turning their foot out, then when they go to push off the toe, automatically the big toe is being pushed in against the second toe because of the mechanics in order to get the toe off. So those were two things I had mentioned. I don't know if they were asking about those.
Thank you. And then there's Laura says, on my left foot, my middle toes have started to spread out and a V has formed between my two middle toes. Can anything be done for that?
The tendons that go to the toes, as I mentioned earlier, you got 4 layers of muscles in the bottom of your feet. Our feet, we really don't give them enough attention. So whenever parts of the foot are starting to react, it's because there's too much tension, something's going on. It's always a good idea maybe to get in there and massage the bottom of the foot. Again, I love the melt method because it does a beautiful way for the fascia. But just getting things massaged, because obviously the tendons that are going to the toes are reacting to something. And so it's a good idea to manually try to calm things down. Maybe something's just, this isn't very scientific, but maybe something's just got its knickers in a twist, and just giving it a little bit of TLC might help.
Thank you. And CN says, do you think the hip flexors and tight QL muscles are probably the most major cause of foot pain, leg pain, and back pain?
I can't say that definitively, the most major cause. Hip flexors do lock short because of all the sitting we do, but there's a lot of other parts of the body that get impacted by the sitting. Glutes, max, when you sit on max, he shrinks, he hypertrophy, or sorry, he becomes, he shrinks. He loses size, he loses strength, and that's your power source. Your hamstrings also, if you're sitting on them and they're getting dehydrated and compressed. So now that's going to impact a lot of things. The ankle function is going to be limited from lots and lots of sitting. I mean, there's so many parts of everything is connected to everything else. So I don't believe it's accurate to say that one part of the body is the biggest offending factor of all kinds of pain and problems, because there are certain areas of the body. And I will say this, there's 3 areas of the body, and I believe I did this once on your show, AJ, where I talked about the 3 main culprits of most pains in the body. It's the trunk, your thoracic spine between your neck and your low back. If that trunk is lacking rotation, which most people are completely unaware of the fact that they've lost rotation as they age because they're not looking at it, they're not training in it, they're not paying attention to it. And so then when they go to turn, all of a sudden the trunk just doesn't want to go. The neck has to make up for it. And now they start to have neck pain or they start to have back pain because the low back isn't really designed to rotate. The trunk is, and the hips are. And if it's not happening above and below the low back, now the low back is getting trashed because of that lack above or below. So the trunk is a big offending factor. The hips or the pelvis can be a big offending factor for back pain, for neck pain, for knee pain. And then the ankles, they can be an offending factor for pretty much anywhere in the body, depending on what people are doing. I mean, football quarterbacks who have unstable ankles will end up with shoulder problems, elbow problems, pitchers, any kind of a swinging sport. Ankles are huge, hips are huge, trunk is huge. Those three areas are what I call the big rocks of the body. And when those are working properly, it can resolve a myriad of pain issues.
Thank you. We have time for one more question. Becky says, as far as stretching, is there anything different to do for a tailor's bunion?
Well, that's the bunionette. That's the pinky bunion. And I am going to be doing a lot more research into that before the bunion challenge. So I really don't have any data, any updated information that I feel comfortable sharing. But I do know that when you improve the ankle function and your hips are functioning well, a lot of things can dissipate as far as pain and symptoms because the mechanics of the body are more aligned with what's authentic function.
Thank you, Eileen. It's a great presentation as usual.
Thank you. And I'm sorry that your voice has been taxed and
What happened?
I admire your willingness to go through with the show and again, we all will very, very much miss Dr. McDougall.
Dr. McDougall, when the news of his passing happened, I must have got over 100 phone calls and even more texts. So thank you all for being here. And please remember the two wonderful books by people that have regular shows on this show have come out today. Can Fasting Save Your Life by Dr. Ellen Goldhammer, who was on the show Sunday. You can watch that now. And The Impactful Vegan by Robert Cheek, who will be discussing his book on Thursday. Let's really try to make both these books not only bestsellers, but New York Times bestsellers. And please come back tomorrow at 9 a.m. Pacific time for Dr. Lori Marbus, the prescription for wellness. And she is going to be talking about what stress does to the body. If you're watching, to everyone in the McDougall family, Mary, Heather, Craig, all the grandchildren, our love is sent to you and our thoughts and prayers are with you. Thank you everyone for watching. Take care. Bye-bye.